This is a lecture on sedation, analgesia, and delirium in the ICU. I will be going through principles of management, basic pharmacology of common drugs used, and I will also be talking about how to manage an agitated patient in the ICU. Pain is a highly individual experience. Incidents of pain and delirium in critically ill patients vary, depending on patient population and the diagnostic tool employed. In some studies, 30% of critically ill patients were noted to have pain at rest, and with routine care or procedures, the incidence of pain increases. Why do our ICU patients have so much pain? A lot of the procedures that we do in the ICU cause pain. For instance, line setting, intubation, suctioning, etc. Mechanically ventilated patients also have a higher risk of delirium. In some studies, incidence of delirium in mechanically ventilated patients are as high as 80%. Why is delirium and pain bad? Delirious patients and patients in pain have an increased stress response, increased agitation, and long-term cognitive and psychological sequelae. Increased agitation places these patients at higher risk of self-harm. Delirium in critically ill patients are also associated with increased length of stay, prolonged mechanical ventilation, and increased mortality. One of the tools we commonly use to monitor our patients in ICU is the Critical Care Pain Observation Tool, or CPOT for short. A score is given based on various indicators such as facial expression and body movements, and a score of 2 or more requires some attention or action to be taken. Our nurses chart the patient's CPOT score in the ICU flow sheets, as you can see on the screen. The RAS score is another commonly used tool in the ICU. The score ranges from positive 4, which is a highly combative and dangerous to staff patient, to -5, unarousable, no response to pain or stimulation. We usually aim for our patients to be between RAS 0 to -2. To achieve this, we adopt an analgesia-first strategy in ICU. Patients are preferentially started on analgesia agents like fentanyl. This helps to minimize the use of other sedatives like midazolam and propofol, and we titrate our drugs to maintain a RAS score of 0 to -2 to avoid over-sedating our patients. This is a table of the commonly used drugs in ICU. I will be going through them in more detail in the following slides. Morphine and fentanyl are opioids that we commonly use in the ICU. Their main effect is analgesia with minimal sedation. The dose of morphine is between 1 to 10 milligrams per hour. Be cautious about using morphine in patients with renal or hepatic failure as the metabolites accumulate. Fentanyl is another commonly used drug. The dose is between 10 to 100 mics per hour. Fentanyl can be used safely in renal failure, but must be used with caution in liver failure. Propofol binds to multiple receptors including GABA receptors. It has anxiolytic, anticonvulsant, and sedative effects, but there is no analgesia effect. The dose is 10 to 150 milligrams per hour, and hypotension is a common side effect. Rarely, it can cause propofol infusion syndrome, which is associated with high doses or use for more than 48 hours. Midazolam is a benzodiazepine that also has sedative but no analgesic effect. There is delayed clearance in patients with liver or renal dysfunction, and in elderly patients, it also increases the risk of delirium. In general, I will avoid using midazolam in my ICU patients unless they have specific conditions like drug or alcohol withdrawal. I will emphasize again that both propofol and midazolam have only sedative effects, but no analgesic effect. Hence, it is important to always start analgesia first, as a lot of the procedures that we do in the ICU cause our patients significant pain. Presidex is a selective alpha-2 agonist which has analgesic, anxiolytic, and sedative effects. It does not cause significant respiratory depression. patients are also more easily arousable and less likely to develop delirium. The dose is 0.2 to 0.7 mics per kilogram per hour. It can cause hypotension and bradycardia in some patients. Presidex is also non-inferior to midazolam and propofol in maintaining sedation. Patients on Presidex are also able to communicate their pain, hence more appropriate steps can be taken to alleviate their discomfort. It has also been shown in some studies to result in a shorter duration of mechanical ventilation and a lower incidence of delirium. So what should I start for my patient who is newly intubated? I will usually start with fentanyl and propofol and titrate the doses to maintain a RASS score of 0 to -2. I will preferentially wean down propofol first, before weaning off fentanyl. The following table illustrates some of the risk factors for delirium in ICU. The steps taken to prevent delirium are similar to what we do for our general ward patients. We should ensure that our patients are pain-free, regularly clear their bowels, and we should try to reorientate them at every shift. Electrolyte abnormalities should be corrected. ICU-specific management of delirium includes minimizing the use of benzodiazepines and using lowest effective dose of sedatives for the shortest duration of time with daily interruptions. If your patient is still delirious despite taking the above measures, you can consider the use of an antipsychotic after doing an ECG to ensure that the QTC is not prolonged. In general, start at a lower dose and up-titrate slowly. If you are called to see your patient who is agitated, first, make sure that your patient is not in pain. Ensure that the analgesia given is adequate. If necessary, add on a low dose of sedation if needed. Examine your patient to rule out reversible causes of delirium like constipation and consider the use of Presidex or antipsychotics. We have come to the end of this talk. Thank you for your attention.